I'm Brian Abrams, one of the senior biotech analysts at RBC Capital Markets. Thanks for joining us in person on day 2 of our healthcare conference. Our first presenting company of the afternoon, day 2, is BioCryst, represented by their CFO, Anthony Doyle, and their Chief Communications Officer, John Bluth. Anthony and John, thank you guys so much for joining us.
Thanks for having us, Brian.
Thanks, Brian.
So maybe just kicking things off on the commercial side. ORLADEYO has continued to show nice growth since its launch. You've talked a little bit on the calls about what you're seeing with respect to market dynamics, but would love to learn more about your latest market research on HAE patients switching off of injectables, what you're seeing with respect to patient retention, prescribing patterns. What gives you confidence in sustainable long-term growth as this launch continues to progress?
Yeah. So just before we kick off, we'll be making some forward-looking statements and refer to our website for risk factors. So it's been a great launch. I think despite having launched into COVID, that's kind of all we know. I think we've never tried to use it as an excuse, has the potential to be a tailwind, hopefully at some point. But it's been really a phenomenal opportunity for us to work with doctors and patients to get them access to, one pill once a day, prophylaxis or prophylactic treatment for HAE. So I think what we've seen to date is steady growth, quarter over quarter over quarter. Specifically when we're talking about the commercial side in terms of new patients on drug. It's been great to see that it's come from the areas that we had hoped it would. So we did a lot of market research. We value the insights that we get from it. And we thought at the time of launch, it was going to be new patients from ongoing prophylactic treatments. So we were going to see switchers. And that we were going to see patients switch over from acute as that market shrinks and more patients move to prophy treatment. So that's exactly what we've seen. And with, what we said is in the first quarter, we've seen 50% of patients who came on in that quarter have come on from prophylactic treatment, 50 have come on from prophy. And from those who are coming on from prophy, it's very much in line with what the market share is there. So 50% of those patients in turn are coming on from drugs like Takhzyro. So it's great to see from both internal analysis and then market research that you're talking about how strong this drug has the potential to be in that market. So from a market research perspective, we do it on a very frequent basis. Our last set of market research was 60 patients who treat on average around 8 patients each, who are prescribing ORLADEYO to about 13% of their patients currently, and the intent to prescribe over the next 12 months was increasing to about 23%. So significant increase. Now, sometimes
and that's in line with some of the survey work we've done as well.
Yeah, and it's, some of it's kind of rose-tinted glasses in terms of the intent to prescribe and the prescription don't often happen as fast as we would hope. But I think it gives line of sight to where we've gone from 122 million last year to no less than 250 this year and onto a peak. I think it gives us line of sight to that ongoing potential for growth within the market. I think in terms of who is prescribing also, we've talked previously about 50% of those prescriptions coming from top tier treaters, which are basically the top 500 in the market who account for about 50% of patients. And then 50% coming from the population outside of that. So it's fairly evenly split and provides, I think, a lot of green space for future growth.
And I guess speaking of growth and line of sight, can you remind us what shapes your peak U.S. sales estimate of $800 million for ORLADEYO and how quickly you believe you can potentially get there?
Yeah, sure. So did a lot of work, like you talked about previously, trying to identify not just via prevalence, but through data, how many patients were diagnosed and treated with HAE here in the US. And we got a number of about 7,500 patients. So based on the ASP that we have and then a gross to net of about 15 to 20%, you're looking at about 2,000 patients on drug that would get you about $800 million here in the US. and have a peak sales number of $1 billion on a global basis, you're talking about 200 million elsewhere coming from rest of the world. Now, 2,000 patients out of 7,500, that's about 27%, somewhere between 25 and 30%. So I think there's a lot of room to take that kind of market share given the drug that we have. There's also a lot of room for other players, whether it be current players or future players.
How quickly do you think you can get there?
Okay, typically
the trajectory's been pretty good so far.
Trajectory's been good. And so how quickly do we go from 250 to that billion? I think here in the US, I think atypically for a drug like ours, you're looking at somewhere around 5-6 years for peak. Rest of the world may take a little bit longer given that the launches have been staggered. There's countries that we will be in that will add meaningful revenue that we're not in there yet. But in a relatively short period of time, I think we can get towards there.
You talked about 50% of patients coming from being prophy naive and 50% coming from existing prophylactics. We'd love to talk about that first segment a little bit more. What proportion of HAE patients may not yet be plugged into an allergist, or maybe who are engaged with a specialist but not yet on prophylactic therapy? And is this an area that you can continue to build out, educate, create awareness around in terms of identifying those patients and engaging them with the right provider, and that they could potentially be encouraged to start on an oral prophylactic?
Yeah, absolutely. When we did market research back in 2019, we'd identified as part of that 7,500 patient population, the split for prophy use versus acute use was about 60-40. We've seen that shrink to probably about 70-30, 70 in favor of prophy, 30 in terms of acute. And the market research that we've done leads us to believe that it could and will go further than that. So maybe 80-20, maybe even 90-10 on a longer term basis. I think in terms of how we address those patients, I think a lot of the work is education. A lot of the work is working with doctors, KOLs, and then patients themselves to talk about the benefit of being on prophylactic treatment versus handling acute attacks as and when they occur. I think if we can reduce the number of attacks that they have, I think manage them better, have them reaching for rescue medication on a less frequent basis. Hopefully you get to the point where in a market where these patients could potentially have fatal laryngeal attacks, prophy is the way to go, and a lot more doctors on an ongoing basis are getting to that conclusion.
And it sounds like, I mean, this is just sort of quick math in my head, but it sounds like even just being able to get to those patients who are, even if the switches off of other prophylactics equilibrate, getting to that population, that 30% of the 7,500 patients who are just on acute therapy now could potentially in itself get you to that peak sales.
Yeah, no, I think it has been and will continue to be a key driver as to how we get there.
Yeah.
Right. I don't think we're overly dependent on either market. We want to have patients move on to our drugs from both areas. But in a market where you now have access to one pill once a day, moving from an acute medication where you don't have to move to an injectable, why would you not try Orladeyo?
And I think we see opportunities for continued growth in terms of breadth, getting more doctors to prescribe, and depth, getting the doctors who have tried Orladeyo but maybe just tried it on a few patients so far to prescribe to more of their patients.
Got it. How's reimbursement? What's the latest on reimbursement access? Is there room to further evolve beyond the 80% you've talked about in your recent earnings call? And what are you seeing any or expecting to see any more aggressive approaches taken by your competitors to try to draw patients who switched off their drug back off of Orladeyo?
Yeah, I think getting to 80% in our first year of launch was, the main target that we had. That gets us all the major insurers, PBMs, et cetera. There may well be incremental increases from here on in. We'll never get to 100%. We're fully aware of that. Could we get to 82, 84%? Maybe. And that's something that we're absolutely devoting time, attention, and investment towards getting more reimbursement for patients on Orladeyo. I think in terms of the landscape of all HAE products on market, I think going to a pricing type dynamic tends to be a bit of a nuclear option. What we've heard is patients and doctors alike enjoy the fact that they have freedom of choice.
Yeah.
And so if you start to do a lot of step throughs, I do not think that that's a winning strategy for anybody.
Okay. Got it. Yeah, it seems like that's not something that's often done in these orphan spaces, but it's always hard to know when a space starts to become increasingly
I
crowded.
mean, the HAEA Society has been instrumental in getting, multiple drugs onto the market in the past 10 years. And so for them, choice is of paramount importance.
You've had pretty good patient retention. What's the impact been of early discontinuations and the primary reasons for that? Is it side effects that maybe physicians and patients are not educated about managing through? Is it breakthrough attacks? Is it counter detailing? What are some of the ways that you might be able to even further improve retention and reduce those early discontinuations?
Yeah, I think if we trifurcate it into, a third, you've got 1/3 of the population who DC would be down to perceived lack of efficacy. You'd get 1/3 where it's GI events, and you'd get 1/3 where it's an other bucket, contained in which is probably one of the other two where we didn't get enough clarity as to specifically why they DC'd. When I look at the timing of it, you've got 50% of patients who discontinue within the first 2 months of usage. I think that's where a lot of our effort and a lot of our investment goes into education as to within that time period, how can we maintain patients on ORLADEYO? If it's GI effects, knowing that for the most part you can treat through, you're going to come out on the other end and hopefully be well controlled on ORLADEYO. If it's perceived lack of efficacy, can you really get there within that 2-month time frame? Are there other underlying factors? So we continue to invest in, as much as we want to fill the funnel at the top, we want to see if we can slow down the drip at the bottom. Now, 2/3 of patients who started ORLADEYO since inception are still on ORLADEYO, which I think is indicative of a strong retention rate. There'll be fluctuations over time. It'll go up, it'll go down. I think where we get to, when we get to peak, will be a good place where a bolus of patients who are on drug will be well controlled on our drug, and because if they're not, they'll have already gone to another treatment.
How do you foresee the market dynamics shaking out over the longer term with potential additional oral entrants?
Yeah, I think there's room, first and foremost. So I think if we go back to where we think we're going to get to from a peak perspective, 2,000 of 7,500 patients, 25 to 30% market share. There's a lot of room for other players, again, whether they be current or whether they be future entrants. I think where they start to take market share from will depend. If it's another injectable, I think they're more inclined to take market share from existing injectables. I think about what, by the time we get to peak, and there's a number of drugs who are in clinical trials at the moment looking to get into the space. By the time they get there, I think we'll be really well established. And so the question at that point is, if you're well controlled on one pill once a day, what is the incremental benefit that you see from moving to another treatment?
Right.
Now, if you're not, that's fine. That makes sense to go with one of the others. But if you are,
Right.
What is better than that?
Right. And you probably would have discontinued anyway if you're not well controlled.
Correct.
Okay. Good. And then can you talk a little bit about the European market and just remind us some of the differences in terms of, obviously you've talked about pricing. I know Europe hasn't been sort of a traditional prophylaxis market, but it seems to be sort of, with Takhzyro and now you guys entering the market, it seems to be shifting that way.
Yeah.
How do you think about balancing pricing dynamics versus patient access, and what do you think you need to do to get to 20 to 30% there?
In terms of pricing, you're going to have to get about 3 patients outside of the US to get to the same value as you get from 1 patient in the US. So there's very much more a volume play. Places like Western Europe, I think, are behind the US from a diagnosis, a treatment, especially from a prophylactic perspective, from a usage of those type of treatments. They're definitely getting better. I would say having an oral treatment there will only help. Having to not have patients start directly on injectables, I think will help transition some acute patients onto prophylaxis. But I think between the prevalence that exists, between the pricing opportunity, and then between you've got how centralized a lot of the patient populations are. So here in the US, again, you do have some really big treaters, but in places like Germany, you might have a single doctor who's treating hundreds of patients. So from a sales force perspective, and then if you can get one of those doctors to start prescribing and start adopting it as their main prophylaxis treatment, I think you can make big inroads fairly quickly.
Okay. Good. Maybe we can shift gears and talk a little bit about 9930. Can you maybe talk a little bit about your ongoing investigation and conversations with the FDA regarding the recent clinical holds for the creatinine elevation signals? And I guess I'm curious what data set you are going to be presenting to the FDA to try to get the partial hold lifted, and whether they've given you any guidance as to what they would want to see to be comfortable.
Sure. And we provided a good bit of detail in the update we provided on our most recent earnings call. And our expectation is that as we have discussions with the FDA, that we'll get to a point by the end of the third quarter where we'll be able to give you some clarity on next steps for the program. And the basis for our discussion is going to be what we've learned in the investigation into the serum creatinine elevations. And so our hypothesis is that these elevations are dose related to the 500 milligram dosing level. And if we are able to reduce the maximum dose down to 400 milligrams and then step patients up to that 400 milligram dose, that could be an approach where we might not see the serum creatinine elevations. And the reason we feel that that's a plausible hypothesis is that as we look back at the data, we have not seen acute severe elevations in serum creatinine in the patients who started at 400 milligrams. We've only seen that happen in 3 patients at the 500 milligram dose level. That represents about a third of the patients that we had enrolled on 9930. And then separately, there's a group of patients who were in the long-term follow-up portion of our proof of concept trial who were stepped through various doses up to 500 milligrams. And about 40% of those patients saw more mild but gradual serum creatinine elevations. And so we haven't seen those elevations start to appear until they were at the 500 milligram dose. We didn't see them at lower doses. Okay. And we haven't seen the serum creatinine elevations in patients who were stepped through lower doses first. So that's the data set we have to form the basis of our hypothesis that would be a good approach to resume the trials. Of course, we've got to discuss that with the regulators, and their view on that will be an important piece of input for us in determining what the next step is.
Okay. Have you had any initial, I guess, KOL input or input from experts in renal toxicity and pharmacodynamics?
Yeah, so we've had dialogue with our data safety monitoring committee and KOLs. We really haven't characterized it other than to say that there's, I think, a broad recognition for the unmet need that exists in the renal conditions that we're studying and in PNH for a drug like 9930. And there's recognition from that community also that the efficacy data that we have generated so far has been very, very strong. That we've shown a reduction in transfusions to 0 or near 0, and we've elevated hemoglobin by over 3 grams per deciliter. So very strong efficacy that we've seen at both 400 and 500 milligrams in the clinical trials to date. And I think that's appreciated. Yeah. And so there's encouragement to sort of fully explore whether or not the approach that we have in mind makes sense or not.
If this toxicity is a peak effect from exposure at the highest dose, at this 500 mg dose, rather than like a cumulative AUC effect, how confident are you that you would have an adequate therapeutic window with 400 milligrams, and that you wouldn't have any exposure overlap with 500 milligrams? I'm not sure if you guys have talked about kind of the individual patient exposure curves, but I'm just sort of 25% doesn't seem like a huge therapeutic window if a drug might have some variability in PK. So I'm just curious, like, how confident are you that you'll be able to thread the needle with 400 based on kind of what you've seen today?
Yeah.
And obviously, the data, the clinical data would support that, but just kind of wondering on sort of a PK/PD basis
Yeah.
when you think about longer term studies with many more patients.
Yeah, so it's a very good question, and so we've kind of reviewed the clinical data, which gives us confidence. We have PK data that suggests similar types of effects that we see clinically, but we also have much less experience at 400 milligrams than we do at 500 milligrams. So we're going to have to run that experiment to really understand the answer to that question, and I think that's part of the discussion with the regulators. Are they comfortable with the approach that we're proposing? And that'll be part of the decision we factor in to next steps, along with the data we see from competitors that comes along at the end of the year. As we look at that data, what does that profile look like alongside the profile that we think we're going to have with 9930? And we get to those answers pretty quickly, and without much spend.
Right.
Either.
Right.
And it'll be data driven. Like it's not an emotional choice to invest, right?
Yeah.
We will only invest in 9930 if it has a path to becoming a commercially successful drug.
Okay.
At the point in time where that's no longer viable, we won't move forward with the trial. As long as that exists and that opportunity for value creation exists, then we'll move forward.
Would you consider still moving forward in renal diseases as well as PNH, just given the tox being a kidney focus?
Yeah. Our goal is to bring 9930 to the market in the renal indications and in PNH. And commercially, that's important. There's a lot of opportunity in the renal indications. And so our answer would be yes, if we can demonstrate that 400 milligrams twice a day is a safe and effective dose. If we're able to demonstrate that, we would want to bring that safe and effective dose to all the indications.
Okay. Got it. Maybe just in the last minute, curious on 9250, the ALK2 program, kind of where that stands. Can you remind us of the mechanistic rationale and FOP? And I guess curious the latest status on some of the chronic tox manufacturing work that you're doing ahead of the clinical studies, what the key limiting factors are there.
Yeah, so BCX 9250 is an ALK2 inhibitor, and ALK2 is the enzyme that's dysregulated in patients who have FOP, which is a horrible disease where tissues ossify into bone. There are no treatments for it. It tends to affect children and adolescents and shortens their lifespan and affects quality of life dramatically. So by inhibiting the ALK2 enzyme, we believe, prevent this sort of hypergrowth of bone in parts of the body that experience bruising and injury. And so far, it's an oral medicine that we have taken through a phase 1 study in healthy volunteers. And we think we have good line of sight to a dosing approach. And this year, we have spent ramping up drug manufacturing and doing tox work with a goal to getting into FOP patients next year.
Got it. Good. Well, unfortunately, we're out of time, but this was great to catch up. And so thanks so much, Anthony and John. Really appreciate it. And thanks, everybody.
Thanks for having us, Brian.